Any questions?
About this.
Okay.
So, okay, thank you. So moving to our next speaker, so we have Dr. Manoj Vithlani with us, and he's practicing as consultant physician, treating diabetologist. He has got several research studies to his credit, and he has been managing type 2 diabetes, has got several international national publications. He is a life member of API, academic life member of RSSDI Gujarat chapter. And sir will be talking today about clinical utility of Basal plus co-formulations in India. So I welcome you, sir, and looking forward to your talk.
Many thanks for the kind words. Many thanks to the REAMS and Dr. Vipul, Dhruvi, and all teammates for an excellent work for the clinic Practical Diabetology. They are now the takeover from the all seniors, that they are doing the best, and best wishes and congratulations to the REAMS and all the Vipul, Dhruvi, and all teammates. My topic is clinical utility of the Basal plus co-formulations. Nowadays, we have a designer insulin analogs. So how to use them, what are the practical difficulties, and what is the take-home message by using them, so the patients are readily accept the new formulations, and that also gives the good control for the diabetes and improves the quality of life as well. So my agenda today is these slides from the Novo Nordics, because they have only a co-formulation, and recently I took the lecture on this. So no disclosure for this. So kindly bear with me for these slides from the Novo Nordics. Agenda is challenge to triumph. A case study in improved control, insulin evolution and innovations, thriving hopes, that the degludec plus ultra short acting aspart, that key to achieving the total control, and it attributes to the beyond efficacy and safety. So first challenge, this is one hypothetical case. Patient Ramesh Srivastav, age 55 years, weight 78, executive. Diabetes duration is 9 years, compliant with diet, exercise, regular follow-up, uncontrolled sugar level, consent about the complications, and HbA1c in 8.9, post-fasting 142, postprandial 224, BMI 27, blood pressure also uncontrolled, hypoglycemia, yes, because not able to adhere with the total diet and nutrition properly, and is because of the uncontrolled diabetes, there are the cholesterol also not under control. Now the LDL goal is 96, that does not mean is a control. When there is a more than 2 cardiovascular risk factor present, we have to keep less than 70, and if already one cardiovascular event, then less than 55. So the criteria change that we have to remember, and microalbuminuria is also considered an independent cardiovascular risk factor. So these patients already on the 3 OAD, sitagliptin, metformin, dapagliflozin, already on statin, telmisartan, and the human premix 12 units before breakfast and before dinner. And challenges, we have uncontrolled hyperglycemia, as the A1C is not under control, and inconvenient dosing because of the executive lifestyle. And this insulin has to take before 30 minutes prior to meal. That is one of the biggest hindrance for the most of our patients. So what we have to do, this is intervention, clinical on FPG 142, PPG 224, A1C 8.9. What is the clinical decision? Patient is not happy with the premix insulin. So what we have to switch to the co-formulation, and one has to remember for the lifetime there are the unit to unit switch and aid to the transference. So no when patients already on premix same dose to be started with the co-formulation as well. So premix unit to unit switch, and the patient shifted to the 12 units Rhizodeg twice a day. Here no need for resuspension. Most of the time, that is a premix regime. We have to tell the patient that shake your vial or the pen in your palm. So there is a even formulation like the occurred, and that is and there is here no need to wait for when you switch to the Rhizodec, and flexibility of the administration with measure meal. And no shoulder effect. This is shoulder effect is one has to understand very well. Shoulder effect because of the premix insulin, either with the Humalog mix with or Mixtard or no mix. There is a shoulder effect. Why? Because of the protamine. Protamine gives the delayed clearance of the short-acting part of the insulin. So there will be a late effect, and the onset of action also delayed. So because of that, patient may have a hypoglycemia after 1 hour after the meal. So this is called a shoulder effect. So why? Because of because of the Nutramine NPH component of the insulin. So here is the co-formulation. No NPH is there. So there is no shoulder effect. So switching to the Rhizodec, effective for the control fasting PP as well, effective reduction, low risk of hypoglycemia, lower insulin dose, mealtime flexibility, improve quality and cost effectiveness. And this also recommended by RSSDI as well. So now insulin evolution. We know the Benting and Best in 1922 evolved first animal insulin, then the human insulin, then monocomponent, and then now insulin analog. A lot has changed over the time. This gives the compliance, convenience, and quality of life. This is the limitation of the biphasic human insulin, as we talked, lack of mealtime, shoulder effect, and there's opportunity for better FBG, PPBG control, and lack of longer duration because of the overlap effect. And biphasic analog also shoulder effect because of the NPH. Only the Degludec and Aspart do not have shoulder effect because of it is a co-formulation. So this is co-formulation advantages, mimics the physiological insulin secretion, no shoulder effect, and simplify the regime because of the because of the shoulder effect. There is a high glycemic variability. No glycemic variability with the co-formulation, and the 24-hour good control, and no need for the resuspension. That is also one. So co-formulation improved study. I was also a part of an improved study. Significant HbA1c reduction, significant fasting and PP reduction, but because only the problem is the hypoglycemia. And switch to this also much improved, much better than the premix regime. So hypoglycemia, weight gain, insulin doses. When there is a